The other question that comes to mind, and I would love to get your input on, what about the patients who require surgery that are on antiplatelet for a recent stent? How do you transition this patient off oral medication to this medication while they're waiting for surgery?
Well, there's been a really, really good study that's bridge to cabbage, but you could use Cangrelor for bridging to surgery after PCI, for example. And a lot of the times we've done this, what we look at is the surgical risk. What's the perioperative hemorrhagic risk? If there's a risk of reoperation, et cetera. And then what you want to do is think about, what am I supposed to do? If there's the highest risk patient is the time from PCI to surgery for non-cardiac surgery, for example. If it's within the first month, it's really high risk. That's a fresh stent. That patient should have some bridging. And of course, it's going to be really important to think about the timing of the primary PCI. And then what was the clinical presentation of the patient as well? That's another piece. What kind of angiographic outcome did they have at the end of their procedure? So it's not just like a one quick answer to the question. You really have to go and dig in. What did the PCI look like? What was the scenario during the PCI? How many stents are there? Did they use imaging? What is going on? And then think about, do I need bridging or not? And if it's a real fresh stent, I think you might need bridging. And then the bleeding risk is important, because then what's nice about with the surgical risk is that you work with your surgeon as a team and you decide how you're going to work with Cangrelor as a bridge.
Yeah, that's really important. Thank you for sharing that with us. The other myth that comes to mind is the idea that, as you know, females have the higher risk of bleeding. Physicians avoid using this medication in female population just because they're worried about increased risk of bleeding. Have you seen that from your experience, a difference in bleeding risk using this medication between male and female?
We have not seen it, but these sex analyses are all underpowered. So because we're already underpowered even for the totality of the data that we have available for Cangrelor, in fact, I think if anything, Cangrelor would have a great opportunity in those patients at a higher risk for bleeding, because it's a quick on, quick off situation. It gives you a prompt, potent, reliable antiplatelet effect. And it overcomes all of the P2Y12 inhibitors that have the delay in their onset and, of course, an offset of action. So in my mind, it's actually a great drug for a woman. But we don't have enough data to say, is there more of an issue between men or women, et cetera?
Mount Sinai is positioned in a location where the patient who comes to Mount Sinai represent the true patient population we see across the United States. There was a study that came from Mount Sinai called the SMILE study that looks at the timing, the indication, the transition pattern using this drug. Can you share with us, if you're familiar with it, what that study has taught your team, and maybe we can learn from it as well, because it's really representing a true patient population?
Well, first of all, I think what the SMILE registry was just an evaluation of our own, how our clinicians were using and adhering to the protocol that we currently have, which is really evaluating and giving and understanding how to transition to the oral P2Y12 inhibitors. But we wanted to see how do all of our physicians who are using Cangrelor are transitioning to these different oral P2Y12 inhibitors. So we looked at that it's a retrospective analysis, but we did look at it in terms of the in-hospital thrombotic or events, including death, MI, stroke, but also bleeding. And we stratified it by the analysis of how you transitioned. So we had about 500 patients. 80% of those patients transitioned to ticagrelor as we had put it together. And then there was about 20% who transitioned to either prasugrel or clopidogrel. And we found that the patients who went on to ticagrelor, which has to do with the fact that at the start of the infusion, we give the ticagrelor. That's the nice way of looking at it. So it's a lot easier because they're already transitioned rather than with clopidogrel and prasugrel, where you are doing it immediately after, or you're anticipating when you're going to stop, and it could be that there could be a delay in getting those oral treatments. Well, we found that adherence also allowed the best adherence to our protocol in terms of how you should be transitioning, and the best possible outcomes with less MACE and less thrombotic events. So the adherence to the protocol was better, and the in-hospital outcomes were better too. So that was sort of because of the way ticagrelor works versus prasugrel and clopidogrel. And it was a very, very interesting. Remember, ticagrelor is also reversible, so is Cangrelor, and prasugrel and clopidogrel are irreversible inhibitors. So it's really important to understand the transitioning. So in our real world practice, the use of ticagrelor and adherence to the protocol was better, and we were able to transition to the oral P2Y12 inhibitor better, and therefore a better outcome. So that was what we found.
No, that's very helpful. I really appreciate the time to shed the light on this one.